Started.
All right, so welcome everyone. It's my pleasure to introduce the monthly webinar of our residency programs. Today we have the honor and the privilege of hosting Matthieu Legrand, who is professor and director of clinical research at the Department of Anesthesiology and Perioperative Medicine at the University of California, San Francisco. Right, Matthieu? I know quite well Matthieu, certainly from his research, and we have also some collaborations. And just to mention a few passages of his tremendous curriculum, he completed, he is originally from France, and he completed his postgraduate training in anesthesia and critical care at the Pierre Marie Curie University in Paris. He got also a PhD degree in cardiovascular physiology at the Sorbonne University, and he became first assistant professor and then full professor of anesthesia and critical care at the Paris Diderot University. His main research interests include, for sure, cardiovascular physiology, shock, acute kidney injury, and outcomes after major surgery and critical illness. I think that Matthieu is one of the leading experts for sure acute kidney injury research. So with that, thank you very much, Matthieu, for your time and availability. And as Thomas mentioned before, we will have time thereafter for questions through the chat box. And now the stage is yours, Matthieu. Thank you very much.
Yeah. Thank you. I'll just say one
Pietro.
very brief thing. Sorry, Matthieu. For all attendees, you see in the bottom on the right the chat box. Please feel free to ask questions. We will summarize all questions that arrive during the talk of Matthieu and ask him at the end of it. So please interact, and this is a good way to interact with a very knowledgeable professionalist and researcher. Thank you, Matthieu.
Thank you so much, Pietro and Thomas, for your kind words. Happy to be here. My understanding that the presentation is about 90 minutes. Is that correct? Yeah. Okay. I mean, if it's too long, or yeah, just let me know, and I can cut off. So good. I don't see anyone at the panel, but good morning, good afternoon, rather, actually, for you, everyone. It's 7 a.m. here in San Francisco. Let me just share my screen. All right. Do you see it?
Yes, we see the screen. We don't see the slides yet.
Oh, you don't see the slides here. You don't see the slides?
No, we see
Okay.
the WebEx page.
Okay, let me try again. All right, is that better?
Yes, perfect.
Okay, cool. So Giovanni asked me which title I will go for. So I told him first the mechanism and consequences of acute kidney injury, and you see here that I added sepsis-associated acute kidney injury because actually, to be too broad, I'll mostly speak about sepsis. There would be a few slides about surgery, but mostly from sepsis. Here are my disclosures. There is nothing to related to this presentation. So, I mean, Pietro, thanks so much for introducing me as a kind of introduction. You know, since one of the goals, it seemed that would be to introduce myself to the group. I wanted to give you a little bit of background of myself. As you can hear, I'm from France. So I did my medical school in Toulouse, and after medical school, so to start residency, actually with my wife, we moved to Paris, and when I was resident in Paris, I took a break 2 years to spend 2 years in Amsterdam, in the lab of Janine Che. was 2 important years for my my trajectory. So I did clinical research mostly on interaction between the cardiovascular system and the kidney in renal physiology. And then came back to Paris. Paris, I was, as Pietro was mentioning, mostly in Lariboisière in Saint-Louis Hospital, where I was there first with Professor Payen in Lariboisière, and then moved to Saint-Louis, where I was a medical director of a burn and surgical ICU there. They built out a new burn ICU, so I moved there to help start and grow this with a burn ICU, and then we merged with a surgical ICU. So that's where I spent a few years between 2013 and 2019. And this is my family, including my dog. My family will be not happy because I don't show my cat as well. But with my family, we moved to California in 2019, so just before the pandemic. And as you know, California, for those who know, I hope you've been able to come, and if not, I hope you will be able. It's a fantastic place. It's beautiful. Here are a few pictures of our life in California. You know, the wildlife and the landscape. It's totally amazing, and you have so many different kind of landscape between, you know, here the Lake Tahoe here, where we can in the summer you can have water sport, ski in the winter. You know, I do mountain biking and running here in the marine headland, which are around where we live. It's absolutely astonishing here. Of course, Los Angeles, and here that's the Carmel by the Sea. You can find most of the most beautiful beaches from west of the U.S., the West Coast. And of course, I didn't come only for leisuring and for exploring, but also to work a little bit. I work at UCSF. Just a few words, UCSF. You see a super big institution and top quality healthcare system in the US, and of course on the West Coast. UCSF is growing quite a bit. We're building new clinical and research facilities. So here you see the main campus, but extended a lot on both sides now. So it's an institution we're doing well. You may think it's very big, and you see here the number of people working for UCSF and the revenue, more than 10 millions, and that's probably now a bit off because those numbers are probably a few years old. But and including the great quality of care, you see kind of the kind of view, you know, we have on the Bay Area. We don't see it very well here, but you see here the Golden Gate and Marin County here, and San Francisco just below the hospital, as that was during one of my run in the ICU. So I welcome anyone traveling to the US to reach out to me, and of course either to visit or to stay longer. And you will see that we have we have had some of your colleagues in the lab at UCSF a few years ago. So now back to the presentation. Here, you know, the electronic medical record we have, it's Epic, it's this one, and you know, when a patient coming in the ICU, of course we write a note, initial note, and that could be the kind of note you could see in a patient admitted to one of our ICU, but I would say probably to almost any ICU around the world. You know, Mr. H, 73 years old, admitted to the ICU for community-acquired pneumonia and respiratory distress complicated by septic shock with AKI due to acute tubular necrosis secondary to hypertension. And a few statements here we'll discuss and maybe challenge a little bit to understand, and I'll try to go over, you know, some of our work, but also work from others which have help understanding a little bit better sepsis-associated AKI over the last decade or so. So here a little bit, that will be a little bit of the layout of the presentation. So first we'll discuss why it's bothering that our patient may develop sepsis-associated AKI, because it has attributable mortality. We'll discuss what is attributable mortality and why patients with AKI die more and have worse outcomes compared to patients without AKI when they develop sepsis. Then we'll discuss a little bit the pathophysiology of sepsis-associated AKI, and because we could spend hours on that, here I will take the hemodynamic angle and to show you that it's very likely that a large contribution of sepsis-associated AKI is not due to hypotension and hypoperfusion, and that other contributing factors. And then I'll finish up with discussing some subanotypes that could be associated with outcomes, and that also could lead to different kind of treatments for patients. So first, sepsis-associated AKI as attributable mortality. And here, what I was mentioning, your colleague, that was a work done by Eduardo Tonecci. You might know him. He was a resident a few years ago. And he spent a year with us. I think it was in 2022, I believe, or 22. I think it was 22. And of course he did outstanding job. And one of the work he did was to explore the attributable mortality of patients admitted to enrolled to NIH clinical trials on RDS. And looking at attributable mortality of AKI in those patients. So as you know, IRDS is the most common cause of acute respiratory distress syndrome and sepsis. A large proportion of those patients have sepsis. And first, before the attributable mortality, you can see that's the name of the clinical trials. So they were all randomized controlled trial by NIH. And you see first the incidence over the years, across the different trials, so from the late 90s to late 2010s, the incidence actually tend to have increased, both from AKI and here severe AKI. So first of all, obviously, we are not preventing AKI in those patients. It might be even the other way around. And then he looked at the attributable mortality. So I won't go into the details of the method, but in other words, that what will be the mortality of the same patient without AKI compared to the same patient with AKI. So you will match all patients to have exactly the same characteristics, the same severity, the same cause of the RDS, the same physiology, of course, for what you can measure. And you compare for the same characteristics those with AKI and those without AKI. And then you compare the difference of mortality. And you can see here that the 90-day excess in mortality attributable to AKI was 15% on average, the median. That means that for patients with a risk of dying of 30%, 15% of the mortality could be attributable with AKI, the patient with AKI. That means that, of course, when you prevent AKI, what you can expect is to prevent this part of mortality attributable to mortality. So, for example, if you design a clinical trial, you say, I want to decrease the mortality of 20% if I have an intervention on AKI. So you have to understand that the mortality you can expect to decrease can only be the attributable mortality, cannot be the overall mortality. And that's lead actually why probably a lot of clinical trials are a little bit or fairly underpowered because we look always at the global mortality and not the attributable mortality. On the right here, you see the 90 days overall mortality in attributed to acute kidney disease. So acute kidney disease is AKI persisting for more than 7 days. And you see that, not surprisingly, when you have AKI not resolving and lasting for more than 7 days, attributable mortality is much higher. So of course that we have good knowledge, and that I think that patients with AKI do worse, they have higher risk of dying, and they have an attributable mortality. But the question is why patients with AKI die more. We have a way to prevent complications for AKI. We have renal replacement therapy. So why would they die more? Of course, there's a lot of potential explanation, but one of them I wanted to share with you is because AKI, we believe, induce a vicious circle. Of course, AKI has been, the risk of AKI is increased because patients are more severe. But when a patient develops AKI, there is now a lot of evidence that AKI damage or trigger inflammatory pathway, damage pathway to other organs, what we call remote organ damage. And the heart, here I'll show you a few data on the heart, but not only the heart, the lung, the gut, the liver. So patients with AKI have also damage induced by the AKI on other organs. So we know from an epidemiological standpoint, we know that also patients with AKI have a higher risk, for example, of developing cardiovascular events. That one of the study from one of my colleague and friend Kathleen Liu here at UCSF and that from the large database from the Kaiser Permanente system in California. Patients with AKI have more risk than a patient without AKI of developing acute kidney injury. Why? That comes from, of course, mechanical studies, animal studies, because the causality and the mechanism are very hard to explore in humans. But here in a review we published, if you're interested, a few years ago, you will see you can see the different mechanism why AKI can trigger cardiovascular damage. So there's a lot of inflammation, activation of the RAS system, oxidative stress. But if you go into a bit more into details, one of the pathways where we believe have been playing a key role is the galectin-3 pathway. That from Mathilde and Louis Boutin were two of my former fellow back in France. That's what we explored. So in animal models, plus also in cohorts of critically ill patients. I won't go into the details of the experiment, but long story short, we could show that when you induce acute kidney injury from different actually kind of injury, ischemic, obstructive in animals, this will trigger from inflammatory cells coming from the bone marrow, release of one inflammatory molecule called galectin-3, and this galectin-3 will go to the heart and trigger inflammatory pathways and then damage and then cardiac dysfunction with reduced ejection fraction. And when you block this molecule, you will prevent the cardiac damage induced by acute kidney injury. The other downstream, of course, like IL-22, the other downstream, of course, mechanism, galectin-3, seems to play a critical role. And we can measure, it's not available everywhere, but galectin-3 have been here for a long time. So there are kits, a way to measure galectin-3. In the plasma, there is commercially available kits. Well, that was what I meant. And for example, in the large prospective multi-center study, you can see here the galectin-3 when patients survive the ICU stay and were ready to be discharged from ICU, you can see here that the galectin-3 level was much higher in patients who develop AKI, and the higher the severity of AKI, the more severe the AKI was, the higher the level of plasma galectin-3 in those patients. And the galectin-3, among other cardiovascular biomarkers, was much higher in patients who develop AKI during that stay than patients not developing AKI. And you see galectin-3 higher. ST2 is another cardiovascular biomarker, troponin, NT-proBNP, and IL-6 inflammatory biomarker. That was ICU discharge. We show it also that patients admitted to the ICU, when they're coming to the ICU here, 2,000 patients coming to the ICU, patients who develop major adverse kidney events, so that either dying or needing renal replacement therapy or having AKI which doesn't recover, at much higher galectin-3, and you see with rather little overlap compared to patients who didn't develop MAKE. The same patient who developed AKI during the ICU stay, much higher galectin-3 compared to patient without AKI, and the same survivor. More overlap here, but you see a survivor and non-survivor show clearly some difference. There is other work, I won't go through too much into details, but I think here we have a kind of nice story of the interaction between galectin-3, AKI, and the cardiovascular system. I'll go quickly across that. There is not only the cardiovascular system which is damaged, and also, and I know in Italy you have a strong interest in acute respiratory distress syndrome, ARDS, but also some epidemiological and preclinical, so mechanistical work, manuscript showing that AKI also induce acute respiratory distress syndrome, ARDS, increasing the permeability of the capillaries and the alveolar membrane, and increasing the risk of pulmonary edema. That I won't go into the details, but if you're interested, I'm happy to share some materials. So that what the consequences and why patients with AKI we believe at least partially have worse outcomes. And then the question is why also patients develop AKI in sepsis. Remember the note from the admission of the patient earlier on, acute tubular necrosis in patients with sepsis. Actually, now there is quite a bit of data suggesting that, of course, in some patients that's possible. It's never black and white in our complicated patients, but probably in the quite a significant proportion of patients in animals during sepsis, patient or animal can develop AKI despite not showing sign of hypoperfusion. And another Italian guy you may know, Rinaldo Bellomo, we miss him very much, but he was one of the clearly a pioneer in showing that sepsis-associated AKI is not mostly driven by hypoperfusion, actually probably the other way around. And that was some of his early papers where he showed that in animals, that was, I think that was in sheep, this one, patient, when you inject a live E. coli in the bloodstream of these animals, actually the renal blood flow increases compared to control animals, despite the creatinine going up. So you have higher renal blood flow, higher and lower clearance with rising creatinine. And also, we don't have a lot of data, but from animal studies, but also a few patients dying from sepsis. When you look, there is some tubular injury. That's true. That's no doubt about that. But most of the time, it's moderate, and there is little necrosis. And a lot of renal cells actually can appear normal. That was a patient dying from sepsis compared to dying to other critical illness. But there are some abnormalities, tubular injury, including you see here some mitochondrial injury and intracranial autophagosomes. So a lot of these patients show tubular injury for sure, but not necessarily extensive acute tubular necrosis. And one of probably the mechanism where there could be some degree of injury is also, of course, the redistribution of the flow between the cortex. And you can see here, same animal model, that the flow in the cortex can increase during sepsis. And the cortex receives 90% of the renal blood flow, and only a small proportion go to the medullary, where the tubular cells are, and the tubules are, with high oxygen demand. And this tubular perfusion might actually decrease. So there could be some redistribution of the renal blood flow in sepsis. And one of the key factors that may explain, not only one of the factors that may explain this distribution are the role of the angiotensin II in regulating the perfusion of the capillaries going to the medullary. So you can see here, these perictural capillaries are being perfused by the efferent arterioles on justa medullaris glomerulus, and here this perfusion can be affected, whether the shunt from the capillary and the efferent arterial blood flow to the cortex. And in other words, here, if you have a stronger vasodilation here of the vessels, and that could be at least partially due to the low angiotensin II or blockage of the receptors of angiotensin II, the AT1 receptor, the high blood flow here can impair the perfusion of these capillaries. That's a kind of cortical shunting that have been proposed, and that nice study from Dan Leishman in New York, who in animal model actually could show that when you infuse angiotensin II to the mice, you can actually, once again, here increase after sepsis, increase renal blood flow, as we discussed earlier. When you infuse H2, actually you restore the renal blood flow to baseline value, and that was associated with a decrease. That's the same actually, a decrease of an improvement of renal function, glomerular function, creatinine clearance, so decrease in creatinine level. Very briefly, this one, it's not sepsis, it's that surgery. But back to the story, of hypoperfusion and hypotension. I very briefly mention it because, first of all, I'm proud of this paper, but also because I think it's relevant to what we discuss. And that was major surgery. It's a randomized controlled trial we did in major surgery, and we tested whether or not holding versus continuing ACE inhibitor and IRB, so angiotensin system inhibitors before major surgery, could have an impact of post-op outcome. So it's both related to the angiotensin II system we just discussed, but also to the role of hypertension. And very briefly, so 222 patients were randomized to either continue the medication until the day of surgery versus discontinuation of the medication. When I was a resident, it was a big red flag. Patient on ACE inhibitor, if they wouldn't stop their ACE inhibitor, they wouldn't go to surgery. Many believe that it was a major risk factor for severe and persistent hypertension and major postoperative complication, including AKI. And what we found is that indeed, actually, patients who continue their medication have an increased risk of hypertension, 54% versus 41% in patients who discontinue them earlier. So hypertension here was defined as mean arterial pressure below 65 and requiring a vasopressor to correct the hypertension. But what was different from when what was, I don't know, said or believed, is that those episodes of hypertension were rather short-lasting, actually. You see here in the continuation were only 9 minutes versus 6 minutes median So difference in only 4 minutes in median. So yes, they do present a little bit more hypotension, but those hypotension are, at least from this trial, not severe and not persistent, and are easily corrected with vasopressors. And that actually, as we mentioned, the kidney and the hemodynamic, it's a complex relationship. And of course, this hypotension, those few minutes of hypotension were not sufficient to increase the risk of postoperative complication. And you see here that was a primary outcome of all-cause mortality and major postoperative complication within 28 days after surgery. Absolutely no difference between the two interventions, and including for acute kidney injury, 11% in each group. 11% is what is very often reported in major, around 10%, between 10 12%, very often reported after major non-cardiac surgery. So absolutely no impact on the risk of acute kidney injury. There were other papers on this. I won't go through all the literature. Again, happy to discuss. But the fact is that it doesn't impact outcome. Of course, one of the question, I'll go fast on this one actually. I'll go fast on this one because I want to go back on sepsis, and I'm happy to discuss the other paper after for question if you want. So what about personalization? Briefly, what I didn't show you that actually personalization on baseline risk factor doesn't impact in surgical patient the risk, at least with the data we have. The way we do the personalization, there's no evidence that personalization of the blood pressure target or personalization based on the baseline risk factors impact cardiovascular outcomes. Back to sepsis or impact outcomes after major surgery. Back to sepsis, we don't have a lot of data actually about personalization. We have a few, and I'll show you one example. There is others, and once again, as a matter of time, we have 90 minutes, but still didn't want to go too broad. This one is a secondary analysis of the sepsis PAM trial. You might be familiar with this trial. It was a trial done in France more than 10 years ago now, investigating the impact of higher versus lower blood pressure target in sepsis shock patients. So target low, 65, 70 millimeter of mercury versus higher, 80, 85 millimeter pressure. Per se, not personalization is exploring higher versus lower. But however, in the initial sepsis PAM trial, the author found that patients with chronic hypertension may be benefiting more from higher blood pressure target because they show lower need of renal replacement therapy in that subgroup with chronic hypertension, and lower incidence of doubling of the serum creatinine. So I wanted to show you here another example of how to explore the methods to explore this personalization, and whether or not what we do at the bedside can be impacted by the baseline characteristic of our patient, what we call the heterogeneity of treatment effect. So that's what we did with my friend Roman Pirecchio, also working at UCSF. We took the data from sepsis PAM trial, and thanks for the support from the lead investigator, including Pierre Asfar. And we apply more advanced methods and modern methods to explore the heterogeneity of treatment effect. And the other word that in that trial, that do some patients benefit more or less from the higher main arterial pressure target based on baseline characteristic. So you see here the different methods. You can read the paper if you want to are more interesting. But in other words, yeah, if there is no heterogeneity or treatment effect, here on the left, overall, all patients will behave the same, either benefit or be harmed or no impact on the intervention. If there is heterogeneous treatment effect, some patients may benefit from the intervention, while others may be harmed or no benefit from the intervention, and that's the goal of these methods. What we found first is that there were no significant heterogeneity of treatment effect detected in sepsis PAM trial. That means that, and you can ask, yeah, but in the initial paper, there was a subgroup analysis showing potential some benefit. There is therefore a high risk because those methods are much more able to detect true heterogeneity effect. There's a high risk that the initial finding of benefit in patients with chronic hypertension was only due to chance. And like the chance is why they are exploratory, the subgroup analysis, and there is a chance that the difference could be only due to chance to hazard. So first of all, here, no subgroup or no characteristic at baseline was associated with heterogeneous treatment effect. But then we wonder whether or not, the response to the intervention could impact. In other words, and that's what we do sometimes in our patient are not doing well. We try to increase the blood pressure, and we see whether or not they do better when we increase the blood pressure. Do they pee more? Does the creatinine improves? So that's what we explored that at a second step. We did a multimediation analysis. And in other words, that you look at what the impact of the trajectory of the resuscitation goal when you target higher mean arterial pressure to inform the strategy. So let's go back quickly. You have a map target assignment, and you look at mediators. So some patient will be in a high blood pressure target, some patient will be in a low blood pressure target. And the mediator, you will look at the mean arterial pressure, norepinephrine dose, lactate, mottling, or urine output. Basically, I think it's a lot of parameter we look at. I increase my doses of vasopressor, does my mean arterial pressure increase as much as I was expected I would like? Then how much norepinephrine I need to increase the blood pressure to my target, and do I reach my target? So if I was in the high blood pressure target, the target was 80, 85. In other words, did I reach my target? Does my lactate go down? Does my mottling score improves? And does my patient pee more in my urine output during the first 24 hours? And then you look at the mortality. And what we found actually is that the trajectory didn't inform which patient would do better. That means that when you target high, so patient when the urine output improve, mottling score improve, lactate decrease, were doing better. That's no question about that. But they were doing better in both groups, both a high and low mean arterial pressure target. So that was not informative on whether or not the higher blood pressure target was doing better regarding that trajectory. However, what we found is that this indirect effect suggested a higher mortality with higher MAP goals when patient needed high norepinephrine exposure or had persistent mottling in the high blood pressure target, which makes sense. I mean, if you increase the blood pressure target, but that requires very high doses of norepinephrine to reach that goal, or when you have mottled skin, so you have probably increased or excess vasoconstriction. Those patients actually did worse compared to a patient in the low blood pressure target. So overall, there were no signal that higher was better than any group, but there was a signal that when you needed high blood pressure, high norepinephrine, or were modeled, high blood pressure target was associated with worse outcomes. So that's that's a systemic hemodynamic, and miniature pressure is only a small part of the hemodynamic of the kidney. And I've been a lot of, especially maybe a bit less now, but some time ago, a lot of attention whether or not the microcirculation could affect the kidney and sepsis associated acute kidney injury. And I mentioned to you earlier that I spent 2 years in Amsterdam when I was a resident to do my master and a part of my PhD. And what we did with Jan Inche, actually, we looked at the impact of sepsis of the microcirculation of the kidney. And here, in animals, of course, and you see here that it's a mapping of the circulation of patient animals. It was rats after LPS infusions, and you see here overall, more red, higher blood flow, more blue dark, lower blood flow. And you see that those animals which were resuscitated, they were resuscitated animals. First, after LPS, there was a hyperdynamic response. But then after a while, actually, and that was a line, actually, what we discussed earlier. But after a while, actually, there were some patchy areas where some heterogeneity of the perfusion appeared, with some area being less perfused than others, with some heterogeneity of the perfusion. There have been many other studies on the microcirculation in the kidney, and of course, one of the questions is, could we prevent or reverse those organ failures, including acute kidney injury, if you could improve the microcirculation in patients with sepsis? And that was the goal of this. The goal of this clinical trial that was published last year, I believe. Yeah, in which we randomized sepsis patient with septic shock and persistent hypoperfusion. I'll get back to that. To receive either placebo or iloprost. Iloprost is a prostacyclin analog. It's a strong vasodilator, but also prevents platelet aggregation, has some antioxidative stress. So a potential very good target for the microcirculation in sepsis. And of course, we had some animal models and preliminary clinical data. But we did this trial, and very importantly, we wanted to have patients who had persistent hypoperfusion, because once again, some patients, the microcirculation might not be the issue. You want to target the patient who might benefit from the intervention. We call that a predictive enrichment. If you target a mechanism that is unlikely to be happening in that patient, your treatment is extremely unlikely to work. So here, this patient were in septic shock and had persistent hypoperfusion, meaning here it was persistent motor skin or increased capillary refilling time, despite resuscitation. So there have been 3 resuscitations, they are on vasopressor, they have received dobutamine if they had cardiac dysfunction, and despite that, they had persistent microperfusion alteration, microcirculation alteration. And it was a phase 2 trial, phase 2-3 trial. So the primary outcome was a change in the SOFA score organ failure. So we randomized 240 patients to receive the medication iloprost for 2 hours, for 48 hours, or placebo. And the primary outcome was a decrease in SOFA score, the change in SOFA score between the placebo and the iloprost group, between admission, enrollment, and day 7. And you see here that was the placebo group, the control group, the change, the SOFA score between enrollment and day 7. And you see that iloprost didn't have any impact on the SOFA score. It didn't have any impact either on mortality. The mortality was the same between the two, so no difference. Of course, it was disappointing, but 2 options here. Either iloprost is not the right target, and you see, patient quite high risk of dying, 40%. They were very sick patients. So either iloprost is not the right target for the microcirculation sepsis, totally possible. It works well in animals, but the microcirculation sepsis has different mechanism. The microcirculatory dysfunction has different mechanism than in animals. Second option, the patient were treated too late because they were already in multiple organ failure, very severe. And even though they had microcirculatory dysfunction, the organ damage were already there. And third option, which I don't believe the case, is that the microcirculation is not a key player in organ failure in sepsis, but I think it's more unlikely. I think the most likely are that those patients were too sick and treated too late, even though we did our best to enroll them very rapidly. And then I finish with sub-endotypes and how sub-endotype exists and associated with outcomes. A bit earlier we discussed heterogeneous treatment effect, whether or not we could identify some patient responding differently from an intervention to another. In sepsis PAM, for example, we couldn't find any. But doesn't mean that there is not different kind of sepsis-associated AKI and different kind of patient that could respond differently to a treatment. That means that I mentioned, based on the intervention that was tested and the data we had available, we couldn't find some heterogeneity. The first sub-endotypes I wanted to share with you very rapidly is that, first of all, there have been a lot of literature on biomarkers. When I was a fellow, a lot of those biomarkers, with a lot of these kidney injury biomarkers or kidney damage biomarker, we were trying to find out whether or not those biomarkers could predict AKI. Most of the time, it doesn't work very well. They don't predict AKI very well. And for a single reason is that there is a disconnection between injury and decrease of function of filtration. Often we take the example of cardiac injury. You can have cardiac injury with elevated troponin. It doesn't mean that you have heart failure. And there are many cases. And for the kidney, it's the same. And it's probably even more for the kidney, because to see a difference, to see an increase in your serum creatinine, which is our biomarker of acute kidney injury, you need to have a very big alteration of your glomerular filtration rate. In other words, you're all here residents or fellow or young faculty. If you have fever, if you eat a steak, a lot of big protein load, you will increase your glomerular filtration rate to 150, 200. Before I was treating burn patients. In burn patients, it's very common to see patients with GFR at 200 and more meter per minute. And of course, your baseline GFR is around 100, but that means that you have this renal reserve. You have much more renal filtration capacity that you need at baseline. But when an injury occurs, you may lose this renal reserve to a point that you are decrease your ability to increase GFR in case of protein loading, for example, or fever. But also, of course, at some point, you may decrease your GFR to below normal values. But even though, you need to have quite a low a GFR to increase your serum creatinine. So that means all this area where you could still have injury, you may not see it with your current biomarkers of acute kidney injury and mostly creatinine. And that was one of the refocusing of most of these kidney biomarkers. We have worked on several of them. I'm just showing one example here, proencephaline. I know Pietro has been working on this one too. And that was the reason I'm showing this one, and probably many other of you. But we kind of redirected the use of those biomarkers exceptionally to detect those patients with acute kidney damage, acute kidney injury, and not necessarily to predict patient who will develop later acute kidney injury. And here, for example, that was from the Frog ICU, 125 patients with sepsis or septic shock. Actually, no, this one was adrenos plus variegation for Frog ICU, so it was twice about 500 patients. And the same, you see the patient who had admission had higher pain kit compared to lower pain kit, a much higher risk of developing major adverse kidney events. But also, and that was true even in patients who had normal renal function quotes based on serum creatinine level. That means patients who were still in the range of acute kidney injury for which creatinine level have not met the definition of acute kidney injury. And that's the term that have been introduced some time ago as a subclinical acute kidney injury. That means that you have positive biomarkers of acute kidney injury, could be pancreas, could be other, could be NGAL, could be KIM1, could be others, but your creatinine is not yet in the range of acute kidney injury per the current KDIGO definition. And what we saw that in that population, actually, when you have subclinical acute kidney injury versus in those population, you have overall an increased risk of death and major adverse kidney events, which actually very close to the one you have in patient with acute kidney injury. So here you have acute kidney injury here, subacute kidney injury, and no subacute kidney injury. And you see those patients, you detect a subpopulation, so a subendotype or subphenotype of patient with those biomarkers that you couldn't detect with only creatinine. And actually, this concept has been introduced in 2020. That was a consensus from AKI in which we contributed, in which the functional criteria using creatinine and urine output, that, as you know now from the KDIGO definition, were added some damage criteria with biomarker and biomarker positive, negative biomarkers on top of the renal function, the usual renal function, creatinine and urine output, as you know them, to define acute kidney injury. And actually, this classification was reproduced, or at least in this concept, with slight changes in the KDIGO, the new KDIGO guidelines, which is was, I think, if they are closed now, open for public feedback, but very likely they will be integrated. Those damage biomarker criteria will be integrated in the acute kidney injury classification in the new KDIGO guidelines. Of course, that's a classification. It's not actionable, and our ultimate goal will be to identify patients, so endotypes of patient based on a specific characteristic of the patient that will be treatable, that you identify a target in that population for which you would have a treatment for that target. That enrichment, and that would be, of course, the ultimate goal. Like a cancer, you have a mutation, you target specifically this population with a specific treatment. We are not yet that in sepsis, far from there, but we are getting closer and closer to that population. And one of the first step, of course, is to identify those endotypes. And there have been some work going on in that field in sepsis-associated AKI. One of the landmark paper from Pavan Bhattacharjee in Seattle in the US, in which he reused data from NIH clinical trial in the VAST trial, in which they explored the group the use of some biomarkers to define using the latent class analysis, subphenotype or subphenotypes. Always discussion between the definition of subphenotype and subphenotypes. So here it was subphenotypes, probably because they were not actionable targets directed specifically towards these phenotypes. But here, you see two subphenotypes, subphenotype 1 and 2, and you see that the phenotypes were mostly driven by ratio of ENG2 and ENG1, soluble TNF1 receptor, ENG2, and a few other biomarkers, and then later on some clinical biomarker. But you see that the phenotypes were mostly driven by those biomarkers, so that you'll have hard time to identify the phenotype based on clinical variables. And what they found that patients in subphenotype 2, had a higher risk of poor outcomes. They were a higher risk of dying, both in the discovery and the validation cohort. And the vast trials they reproduce these subphenotypes, and they observed it's exploratory. It's always post-hoc analysis of randomized controlled trials. The patients were not randomized on subphenotype, so it's exploratory. But still, the subphenotype one, that the less severe patient, appear at least to show a benefit of vasopressin compared to placebo in that group. That means that patients treated with vasopressin belonging to subphenotype 1 seems to be dying less than patients treated with placebo in the subphenotype, an observation that was not found in subphenotype 2, so patient less severe. So yeah, maybe a population that could be enriched to one strategy of vasopressor versus another based on these biomarkers. Very briefly, another example, and that the collaboration we have also with Pietro actually, trying to do some validation. I cannot go into much detail because it's under review, and there is a patent, so are not allowed to disclose all the details. But overall, 3 multi-center studies in patients with sepsis-associated AKI, adrenos, 219 patients in Europe, patients with severe sepsis or septic shock who develop AKI. The early study that was single center at UCSF, 169, and the revival trial, which was a multi-center clinical trial in Europe on sepsis-associated AKI. We investigated the impact of ilophosphate alpha, is recombinant phosphatase alkaline, to prevent a complication from sepsis-associated AKI with the goal to decrease mortality. And what we found that using very advanced clustering techniques, that means, there are a lot of debates on which technique. You can have very different results, depending on which technique you use to identify clusters of subphenotypes. And here, in a nutshell, what we did, we used the adrenos cohort, the discovery cohort, and we used an ensemble method. That means that we combined 12 different techniques of clustering, and as the algorithm selected the most stable cluster in this cohort, and that what we reproduce then in the early and revival. And so we found very reproducible clusters. You see in adrenos here and early. I cannot give you the detail of what driving the cluster, but hopefully you be able to read it soon. And once again, one cluster had higher mortality than the other cluster, both in adrenos in early and revival. And the cluster were very reproducible. That means we have more than 95% concordance or validation between the two cohorts. So very stable clusters. And this cluster was driven by 360 protein, but we could restrict actually what was driving the cluster by only 7 proteins, and with actually the same accuracy. That means the stability of the cluster remains the same whether you use those 7 proteins compared to 366 proteins. And we explored the, once I remember, I mentioned we use a revival cohort, whether or not idofotase alpha would prevent a complication from sepsis-associated AKI. It was here mortality. The revival trial was negative. There was no difference in mortality in patients treated with a drug compared to treated with placebo in sepsis-associated AKI. But we explored whether or not the treatment may be associated with different outcomes depending on which cluster or which subphenotype the patient belonged. And what we found that in subphenotype 1, actually, the treatment had a probability with using a Bayesian analysis, a probability of improving outcome of 98%, with a probability of unfavorable outcome only 2%. So very high likelihood of improving mortality, improving survival when treated with a drug in subphenotype 1. And this was not reproducible in subphenotype 2 with only 80%, which is low, 80% probability, or at least much lower probability of benefit in subphenotype 2. That means that if the drug would work, it's very likely she would have higher chance of working in subphenotype 1 and not subphenotype 2. And I'll finish quickly with this paper, because that's a perfect example of subphenotyping and subphenotyping and targeting a subphenotyping patient with sepsis. That was published a few months ago now in Lancet Respiratory Medicine. It was a Tigris trial, which explored the polymyxin B chemoabsorption in endotoxemic septic shock. So a multi-center, open-label, Bayesian randomized controlled phase 3 trial. It was funded by Spectral, which is a company distributing the polymyxin B chemoabsorption. Long story short, what's the background of Tigris? Tigris was especially designed to target a population, like we remember in iMicro, we targeted patient, we enriched patient who had persistent hypoperfusion, believing that targeting patient with hypoperfusion with a drug that targets microcirculation is more likely to work. You enrich to a population more likely to benefit. It's predictive enrichment. And Tigris follows previous works on of hemoperfusion in septic shock patient, and especially the Euphrates trial, which is this trial on the left here. And the Euphrates trial was a trial, a multi-center trial, which investigate already some patient enriched with circulating endotoxin activity assay. That means patient with high endotoxin level above 0.6 were randomized to receive hemoperfusion, polymyxin hemoperfusion or standard of care. Unfortunately, this trial was negative. There was no difference in outcome. It was published in JAMA in 20. I don't remember actually exactly which year. I don't want to say anything stupid. But what the author did, they looked at a subpopulation for which the endotoxin level was high, but not too high. And why? Because this way of measuring, we cannot measure directly the endotoxin in the plasma. It's very complicated. So you use a EAA with endotoxin activity assay that measure actually the burst the oxidative burst of neutrophils were exposed to LPS in blood. But this assay, is associated, of course, with the endotoxin level here, but the assay is not, doesn't show a linear relationship. It's exponential. That means that patient with EAA above 0.9, there is an exponential relationship between EAA and endotoxin. That means that you can have very high level of EAA, of endotoxin in that range, and maybe just probably too high. At least that was the hypothesis, too high to show an impact on hemoperfusion, because the cartridge wouldn't be able. Yeah, because I forgot to mention the goal of the cartridge is to absorb endotoxin when in contact with the blood of patient. So what they did, actually, they did a subgroup analysis, a post-hoc analysis in the EPHRATIS trial, looking only not at all patients with positive EEA, but the patient with EEA between 0.6 and 0.9, which was considered as a potential treatable population. And indeed, in the EPHRATIS trial, they found that patients treated with polymyxin B hemoabsorption, so absorbing endotoxin, had better outcome compared to the patient randomized to the standard of care. So the TAGRIS trial was designed to confirm those results of the impact of hemoperfusion with a polymyxin B hemoperfusion in patients with endotoxin-linked septic shock within that range of EAA. So that both using prognostic enrichment and predictive enrichment. Prognostic enrichment, you enroll patients at high risk of showing poor outcomes, so severe patients. And predictive enrichment, you enroll patients who are more likely to respond to the intervention. So the inclusion criteria actually were the same as the EPHRATIS trial, because the TAGRIS trial was designed as a Bayesian analysis using prior information from EPHRATIS. So you want to be able to compare the two trials. So patients were enrolled where, if they were in vasopressors for at least 2 hours and up to 30 hours prior to randomization, they have to be in multiple organ dysfunction with a MOD score above 9 or SOFA score above 11, to be at least on mechanical ventilation, to be thrombocytopenic, or having low urine output. And of course, they needed to have an EEA between 0.6 and 0.9. Here, the TAGRIS and the EPHRATIS population, you see, so 106 patients, so it was a randomization 2-to-1, 106 patients were randomized to the polymyxin B absorption, and 51 in the standard of care. And here you see the population from EPHRATIS. And you see overall very similar population with pretty severe patients, SOFA score 14, 13, 13. Very similar population, which aligned with the inclusion-exclusion criteria. Primary outcome was 28 days mortality. It was a Bayesian primary analysis. That means, the data from TAGRIS, for the patient enrolled in TAGRIS, were informed with a 75% weight from the data from the EPHRATIS trial. The survival curve, you see the crude mortality, so that's the mortality observed in TAGRIS. The polymyxin B treatment had a mortality at 28 days, which was the primary outcome of 38.7%, and standard of care of 45.1%. with adjusted logistic regression, marginal mean risk reduction of 10%. Once again, the primary analysis was Bayesian. So here, using the Bayesian analysis, the adjusted odds ratio to decrease mortality was 0.69 in TAGRIS when patients were randomized to polymyxin B hemoabsorption compared to placebo, with a 95.3% posterior probability of benefit. And the trial was powered and designed to show a benefit of at least 95% probability of benefit at day 28. That means that the trial was positive on the primary endpoint of 20 days mortality. 90 days mortality, actually the difference was even broader, with a polymyxin B showing a mortality of 43% versus standard of care 60%. And once again, the Bayesian analysis using a prior with a Freighty showing an adjusted odds ratio for mortality of 0.54 with a posterior probability of 99.4%. So very high posterior probability of benefit of polymyxin B for 90 days mortality. So I was a bit faster than 90 minutes. That's fine because I skipped a few slides. But to conclude, and I hope I at least open the debate. That was the first slide, of my HMP note as my patient coming to the ICU for community-acquired pneumonia with patient with AKI, maybe related to acute tubular necrosis secondary to hypertension. From what we learned, ideally, probably in the future, we'll be able to classify and to better characterize this patient, and probably, and hopefully, we won't write any more of that patient AKI due to ATN. First of all, because we cannot measure ATN, because we can measure acute tubular injury, and probably if there's tubular injury, the different level of acute tubular injury, and probably little necrosis, and we'll probably classify him as a type 1, for example, sepsis-associated AKI. It could be type 2, it could be type 3, or it could be driven by one biomarker versus another, but at least some level of classification. And ideally, this subphenotype could be used as enrichment or selection for a specific drug. And this, for example, type 2 specific sepsis-associated AKI could be a candidate for this drug or that drug, or for example, as we just discussed, polymyxin B hemoabsorption if the patient is endotoxemic. So that's all for today, and you have my email here. Have a loss threshold to send me an email if you have questions or any request, and I'm happy to discuss with you now.
Thank
I'll
you.
stop
Thank
sharing
you.
maybe for now.
Yeah. Thank you. Thank you very much. Thank you, Matthieu. This was really an outstanding presentation, and thank you again for doing it also after your call. So we really appreciate it. So we collected several questions. I will start from one which relates to the last topic, which is polymyxin B. So the paper that you showed is really interesting and relevant. And I would like to know how you changed your clinical practice after that study. So in which patients you use polymyxin B, and if you think that given these results, measuring EAA is mandatory to actually start such treatment.
So two things here. First of all, I think you have it. Do you have it available in Italy, the polymyxin B?
Yes.
You have it. Okay. In the US, we don't. It's not FDA approved yet. So that's in the process for FDA approval now, and Tigris was mostly designed actually for the FDA approval process. So it's in the process. We hope it will be approved. But for now, it's very complicated to use it outside of a clinical trial because it's not FDA approved. The first point, but we hope it will. The second point, indeed, that the question of EA is not super easy, to be honest, and it's not available everywhere. So yes, ideally, you will want to measure EA, and ideally, we will want to have a way to measure EA faster and easier than the current technique. So that the scientific answer would be yes, you will want to have the assay available. That being said, if you enroll the patient with this clinical inclusion-exclusion criteria, actually only a small proportion of patients, not a small proportion, but only about 40%. So when you look at the flow chart, about 320 patients were at the inclusion-exclusion criteria and agreed to have EEA measured. And among them, about 40% were not enrolled because they were out of the range of the EEA. You see? So in other words, using the inclusion criteria, clinical exclusion criteria, you capture a lot of these patients. But that's true, there is a risk that those patients we have low EA or higher EA than they were in the range. So ideally, yes, you would want the EA, which is not, we know that which is not widely available now. I think if at least in the US, if the countries get available, there will be a development of point of care test or way to measure EA in an easier way.
Thank you. But do you think that, so I completely agree, and it's difficult to measure EAA. We actually are not able to at the moment. But the point is, if there is a benefit in that category with a certain EAA measurement range, do you think there could be harm outside that range? So is that a good reason to be very careful with the use of polymyxin without that range? Beyond
so
that.
in the yeah, so in the I think let's try to keep it concise. Overall, there have been one trial showing potential harm with polymyxin B. That was the Abdomix trial. It was a randomized controlled trial done in Europe, in France, actually, mostly, only. I was fellow actually when patients were enrolled. There were abdominal sepsis, and patient randomized to polymyxin BCM absorption had worse organ failure, especially lower platelets, and a non-significant higher risk of death. Those patients, however, were very different from the patients from Euphrates and Tigris. They were much, much less sick, with a risk of death about 15%. So there were abdominal sepsis, but overall with much less severe severity. And yes, so if you enroll patient non-severe, and abdominal sepsis is not enough it's not a good surrogate for endotoxemia. You can have abdominal sepsis and not having endotoxemia, and you can have endotoxemia even with a gram-positive sepsis. So you cannot predict for that. So yes, it could be if you enroll the wrong population. From the Euphrates and Tigris trial, so when you enroll very sick patients, there were no signal of harm in any subgroups. The very few side effects, actually, and the few were related to placing a line. So I think that most of the risk is because of placing a new line. So a lot of those patients actually are very sick or already have a line for CRT. And there were no signal of harm in the Euphrates and Tigris trial. So to the question, if you use the same inclusion, I mean, patient with septic shock and multiple organ failure, severe patient, there is no reason to believe that there is a risk of harm, especially if you have already a catheter when using polymyxin, but there is a risk that the patient may not benefit.
Thank you. Thank you very much. There's another question. Just one moment, I'm going to read it. So in sepsis, do you think that AKI attributable mortality is also preventable? So is there the interplay, the question is about the interplay about attributable and preventable mortality in AKI sepsis, in sepsis AKI.
That's a very good question. Hopefully, yes. Otherwise, I will retire a bit earlier. I think I still have 20 years to go, but ideally, yes. We hope that if you can prevent some AKI, you will prevent some deaths. That being said, the problem with AKI in sepsis that you don't really prevent AKI because patient coming to the ICU with sepsis, you can prevent a bit, sometimes abdominal sepsis, you can see them a bit earlier, you're in the OR. But let's say the vast majority of sepsis coming to the ICU have AKI upon admission. So when you see them, they already have AKI. So the big leverage to improve mortality is both improving recovery from AKI, because once again, prevention of sepsis AKI would be very complicated for that reason. But it's prevention is improving recovery from AKI, making sure that patients recover as fast as possible from AKI. That was the idea, for example, of the revival trial. To patient had AKI at enrollment, and to prevent the complication of AKI. Once they develop AKI, all this vicious cycle of multiple and systemic organ injury that you could prevent. And that also was the idea of these drugs. You prevent. So there are some. We are still a long way to go, but there are some thoughts on drug, interacting with the glycan-3 pathway, inflammation, and so on. I have to be honest, for now, it's only we are far from that, from these specific drugs. But overall, it's prevention of persistent AKI and prevention of remote consequences of AKI. We don't have much intervention. Polymyxin B is maybe one of them on severe with severe AKI, but the rest is mostly still research. And and one of the issue we have clearly is that the industry is not very keen to explore. There are ongoing trial on sepsis associated AKI, but still overall there is little interest from the industry on developing drug for that population. But yes, to the question, if we believe there is a prevention of AKI, of mortality attributable to AKI, yes, if you improve. And beyond those drugs, you have also all the good care you can do. And for now, in the absence of drug, good care is to make sure that the patient is adequately treated with sepsis, with a good antibiotics, with a good source control, with making sure he's not hypovolemic or congestive, to have a refined hemodynamic management, to make sure that blood pressure is okay, but not too much vasopressors, to make sure that you treat cardiac dysfunction or low cardiac output, I would say, when there is one, to make sure that you don't give unnecessary nephrotoxic drugs. There is also very actionable things you can do on a daily basis, pending these more targeted therapies.
And still, do you think that CRRT could have a role in this, in kind of changing the trajectory of sepsis-associated AKI and the associated mortality?
I think it's absolutely have no role. I'm very convinced about that CRT does what it is for. That means treating the complication from AKI. High BUN with consequences, high kaliemia, high potassium level that not can be treated, pulmonary edema. The only situation, but you rarely see that in sepsis, but the only situation I think CRT can have really a therapeutic goal beyond treating the complication of AKI in when patients are very congestive and have a congestive AKI, and that you are not responsive or not responsive enough to diuretics. So that is for fluid removal. But to be honest, it's not very often in sepsis. We can see that. You have to be careful. And we can see that, for example, congestive in sepsis. But that's, I would say, the only indication for which I would say CRT has a true role in preventing and improving recovery from AKI. Otherwise, all the literature suggests that unnecessary use of CRT delay recovery from AKI and produce some potential acute kidney injury.
Great.
But
Thank you.
when they are congestive and you cannot achieve your goal with diuretics.
Great, thank you. There is a question from a colleague, Katerina Stomaci. She asks if you could please tell us a bit more about the lung injury caused by or associated with septic AKI.
About the mechanism, you mean?
Yes, the mechanism was indeed.
Yeah, so the mechanism, it has been less explored than cardiac injury, but there are few preclinical paper showing like when you induce AKI, you see increased permeability of the alveolar capillary membrane. So you have a true acute lung injury in animal models when you induce AKI. It's not only fluid overload, there is increased permeability. The mechanism, I think, is less. There have been some oxidative stress players here, but I think, at least as far as I know, there is less targeted pathway like IL-3 or IL-22 compared to the cardiac injury. But yes, there are some true acute lung injury. And on top of that, you have the other contributor, which is patients with AKI tend to be more fluid overload and have higher capillary hydrostatic pressure that can also favor pulmonary edema. So you have both a contribution of potential higher capillary hydrostatic pressure plus increased capillary permeability. I don't know if that's answered the questions.
Yeah, perfect. Thank you. Well, the last two questions. So one is my personal question. I work in a burn ICU as well, like you are doing or like you did. And it happens to us sometimes, well, quite frequently, to have problems with hypernatremia in burn patients. I think that's quite common. And sometimes it is so difficult to treat, like right now we have a patient like that, that we start CRT to manage also hypernatremia. What is your opinion about that? Did this happen also to you?
I have to be honest, I've never started CRT because of hypernatremia alone. I feel that, yeah, it's impressive. Burn patient can have very impressive fluid requirement. But overall, we tend to use, for fluid resuscitation, we tend to use only lactate ringer, which are slightly hyposmotic. And when they became hypernatremia, a lot of free water, either through the NG tube or adding some the 2.5% glucose 2.5%. And overall, I don't remember having any true issue to manage, but I don't remember having started CRT before hypernatremia.
All right. Thank you. So the last one, I think, we have a lot of residents listening, and you started by telling us that you spent 2 years off in Amsterdam when you were doing your PhD, and to whom and why would you suggest to make this step? So to take some time off from clinical activity and just take some time for research, sit down and do experiments and study. To whom would you suggest it and why?
To whoever whoever wants to do it. And I mean, it's the same, I feel it's the same like medicine. When you go into medicine, when you are not yet interested, not super motivated, it's hard. I mean, it's hard when you don't love it. So you have to really love it, want to do something else than clinical care. I love clinical care. I think to be honest, um, for for a professor with kind of significant research activity, have a heavy clinical load because I like it. I tend to do more clinical work than I could do. Because I like it, but also I like doing non-clinical work because I find my balance doing I'm curious and I love taking care of patients, but I'm also very frustrated sometimes of how little we know when of the condition we are treating. So I find very well my balance, and so first I started with preclinical models and animal models, which very satisfying to understand the mechanism, the mechanistic, and so on. But then I switched to now I'm doing only. You saw a few of my preclinical models, then I move only to clinical research. Not because I didn't like, but I felt it was a better fit with my clinical work. It was better. It was easier to balance with my clinical work to do clinical research. And I also felt that some people can do everything, but myself, I felt that doing everything, I tend to do less quality or less quality work when I was trying to do everything. So, in other words, you have to want to do something other than clinical work, to be curious, to explore. It's okay to change your focus and to start with a bit of preclinical research, do clinical research afterwards, or the other way around. We have very long careers. Things are going fast. You have time to try and to fail. That's okay. The clinical, sometimes I hear, especially, I think the pressure is less, to be honest, in Europe than in the US. In US, a lot of residents have rushed to finish their clinical training because they want to be attending and earn more money. In Europe, it's probably less, there's less pressure probably because the difference is probably less and there is less pressure money. But what I'm trying to say is that taking 2 years off to explore something else at the end of your career won't make any difference. Either you liked it and it's great, you will have a clinical scientist career. You don't like it, you could have good time. Amsterdam is nice. You can go biking and do other stuff you want to do. And at the end of your career, 2 years more or less won't make any difference. And I think it opens a lot of both curiosity. You meet different people. You can travel. You don't have to be. I'm probably on the hyperactive side of the spectrum. So working a lot and doing a lot of stuff. You don't have to necessarily to sacrifice everything else to do clinical research and to do a clinical scientist. You can find good balance. So if people want, I would strongly encourage them to do that. I think at least myself, it's I would be, and we see that, we see doing only clinical work. I mean, it's very rewarding, but it's hard. And I think having an escape with some exploration where you can have time to explore some research interest is also very satisfying.
Thank you.
But that's very personal.
Thank you.
Thanks a lot, Matthieu.
And I know if I do that, I think, people that I know who have taken a few, first of all, you can still do a little bit both. You can sometimes, when you are in the US, for example, you cannot do clinical work if you go to the US. But in Amsterdam, I was still doing a little bit of clinical. I was still doing a few night shifts and so on. So you can keep a little bit of clinical work. But what I wanted to say that most of the people, I would say the vast majority of people I know who took 1, 2, 3 years off to do something else had very good memories of those times.
Yeah, thank you. Thank you
and often they miss that time.
Yeah, thanks a lot, Matthieu. I mean, the last answer of the last question was really a great conclusion of our talk, of your talk. Very inspirational. I think you showed very well the the right balance between doing research and clinics. And actually, this was also the experience, I think, of Thomas, or myself, and many others. Also taking 2 years off and trying to do also research, starting from curiosity, as you said, and motivation. So thanks really a lot of what you have said and what you showed us. So this is the conclusion. I remind you that we will have another webinar in June, June 11, if I'm right. We will have Professor Giuseppe Foti, who will have a lecture on CPAP. I think that Giuseppe is one of the leading experts on CPAP. So we will enjoy it. We still have to define the title, but this will be the topic. So thanks a lot, really, once again, Matthieu, for your time, your lecture, and what you have showed us. And thank everybody, and we will see you in June once again.
Thank you so much,
Bye,
everyone.
everybody.
Take care.
Thank you, Matthieu.
Thank you.
Thank you. See
Thank
you soon.
you. Thank you.
Bye bye.
You're welcome. Bye bye.
Bye bye. Bye bye.
Bye bye, Matthieu.